us when you started the recording?
Yes, so the recording is now on.
Okay.
Okay, good morning. Welcome to the March meeting of the Mental Health San Francisco Implementation Working Group. I now call the meeting to order. Please note that this meeting is being recorded on web. The recording will be available on the Mental Health SF website. I will now read the land acknowledgement. The San Francisco Department of Public Health staff acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors of living relatives of the Ramaytush Ohlone and by affirming their sovereign rights as First People. Okay. Today we have the following meeting goals and presenters for our meeting. We will receive an update from Dr. Kunin, the Director of Behavioral Health Services and Mental Health San Francisco. Receive an update on the staffing and wage analysis from Wendy Lee with the Controller's Office and the plan for upcoming IWG meetings. All right, Chair, we are moving on to discussion item number 1, our update from Mental Health SF Director, Dr. Henry Kunins. Dr. Kunins joins the Mental Health SF on a regular basis for updates. We're excited to hear what you have to share today.
I just want to say you, I believe, have a very hard stop at 10, right?
I do.
Okay, so we're gonna,
You're gonna manage me.
we're gonna
Okay.
move along and probably like try to keep questions till the end and then. of course,
Well, I think the end of each section.
End of
So that
each
we can get
section.
our presenters.
Okay.
Yes.
So just thanks. I feel like we're all like sprinting right now. Just say what I'm gonna do, what we're gonna do. So I'm being joined. This group have asked specifically about F1 and SB 43. So I'm joined today by Susie Smith from the Human Services Administration, and she is going to, I think, speak about FOPF. And I'm also joined by Director Jessica Brown, who is the VHS Director of our Justice, Equity, Diversity, and Inclusion section. And in that section is the Health Services Act, and Director Brown is the director. And she will be addressing Prop 1, and I'll be speaking. And then I will do SB 43, time permitting, and if we don't fully have time, we will finish. We'll finish next time. Let me just, if I can, Susie, just say a word just to acknowledge that Prop F passed. We have been, the behavioral health folks have been supporting the HSA in thinking about the planning and how we can work together to implement. So, and Susie's been a great collaborator for us and with us. So to you.
Thank you, Hillary. I appreciate the collaboration so far. It's, it's going to take a village to figure this out, so I appreciate that. And the opportunity to talk to all of you and get some of your input on this proposition as well. So we estimate that about 700 accidental overdose deaths occurred in San Francisco between September 2022 and August 23. About 94 individuals, 13% of the overdose population were our clients, were CAP clients. So they're receiving general assistance or CAP here in San Francisco.
What percent?
13% of the total deaths. Yeah, we're recent CAP clients, and then 9% or 62 were participating in CAP the month before they overdosed. So obviously, I mean, the goal here is to be able to, decrease that percentage and to use our touch point with these clients to be able to offer and engage them in treatment options. So that, we can use all of, we have a lot of touch points, and it's basically being able to say at each touch point, how can we engage people in treatment and offer treatment? So the Prop F, which, as you all know, passed, requires that people that are receiving CAP engage in some sort of treatment, broadly defined, if they're found to have a substance use disorder after screening and then further evaluation. It doesn't require testing explicitly. It does not require testing. It doesn't apply to legal drugs. So it doesn't apply to cannabis. It doesn't apply to alcohol. It's really focused on opioid overdoses. And it doesn't require sobriety as a condition of being in treatment. So just, I think there's been a lot in the media and trying to explain what it does and doesn't do to you guys. So just a little bit about CAP. Right now, we have about 5,300 people enrolled in the program. It includes single adults without any dependents. And about 21% of the population is unhoused. Folks get about $712 a month in benefits if they're housed, about a little over 130 if they're unhoused. And the state law governing CAP explicitly allows for this condition of receipt of benefits to be engaged in. Some other counties are doing it as well. Currently, we screen all of our CAP clients to understand what their needs are and whether or not they're on a path towards job training and employability, whether or not they're on a path towards SSI advocacy. We have a robust SSI advocacy program. There's a lot of dually diagnosed folks in that program. Those folks would not be subject to this or this proposition. So for folks that are on SSI advocacy, that's the requirement. Unfortunately, like CAP is a program that comes with requirements, no matter which path you're on, it's a requirement. People who we suspect have a disability, we help them get on SSI, and participating in that is the requirement. So those folks would not be subject to this proposition. We would offer, and it's easier to prove the SSI advocacy case if we can get people into treatment and be able to disaggregate the substance abuse from mental health disorder, but it's not a requirement. For people that are found that we think, are on employment path, and we offer job training, we offer job placement, we offer subsidized wages for folks to get them into employment. So just to kind of level set that there are requirements already with this program. When we currently do our screening for all of our clients, that's when we figure out what path they're on. So what this would do would add additional screening questions to the screening we already provide to figure out if there's a potential substance use disorder. And if we found on the initial screening that there's a potential substance use disorder, that's when we would do a more in-depth evaluation and then work with a provider to figure out what's the best path towards treatment. If there is not a treatment option available, which we don't anticipate because we are partnering so closely with DPH, then the client would not be subject to this requirement. Just to understand, in terms of the types of treatment, we are thinking of this really broadly. So it could be counseling, it could be peer groups, peer mentoring, it could be, medication-assisted treatment. Our understanding is that's the most effective treatment for opioid. Withdrawal management, and we think there's a smaller number that are going to be appropriate for residential treatment. But it's not like there's a lot of concern about the capacity in the residential treatment program. The majority of people are not going to go that path, and it's going to be a conversation and figuring out what is the best option and what is someone willing to do, right? So that's going to be our goal, is to engage them in some sort of treatment and sort of begin a path. Many of our clients are already supported by DPH, so we did a data match to understand how many CAP clients have been diagnosed with an SUD already and how many are in treatment within DPH's system. And we found that 29% of our current or recent CAP clients have already received a diagnosis from a provider within the San Francisco Health Network, and 42% of current or recent CAP recipients with a diagnosis are actually already engaged in treatment.
So 40% of that 29%.
Yes,
Okay.
exactly.
What percentage these slides after?
Oh, yeah, that'd be helpful.
Yeah, I can read it. Yeah, these are sort of more my notes, but yeah.
Something with these.
Yeah, sure.
So engaged means, what's the definition?
So that's something we're actually been having a lot of conversation with DPH about, and I mean, we want to see them doing something.
Oh, no, but when you said they're already, 40% are
engaged.
already engaged with.
Yeah, but what is your
DPH.
criteria, right? Also, so they keep them. This is a condition, right, to get the cap?
Right. So,
Okay, sorry.
yeah, well, they're two different.
Yeah,
like-
I wondered the other question.
Right, so, and that's actually frankly something we've been having conversation about, like what level of engagement meets the criteria. I mean, we are looking at most likely at this point, monthly, some sort of participation. So that could be NA, that, could be peer counseling, that could be, math. We're going to need to see that there's some sort of participation in some kind of treatment monthly. But we're not necessarily in our workforce programs, and we're having a lot of, internal debate about this. In our workforce programs, you have to do a certain number of hours, of work in order to maintain CAP. I think this is different. I mean, I think for us, any engagement is good engagement. And so we're not gonna, I mean, at this point, and we are new, right, this passed a couple weeks ago, so I'm like held accountable for, a statement I make right now, but at this point, I am not thinking of that it's gonna be the same. It's not gonna be, you have to do X number of hours per month in order to meet the requirement. We want to see people engage, we want to see people start in their pathway. If they're not, if you go through a month and they're not participating in NA and they're not participating in any of the service that's been, recommended, then that would be disengagement, right? That's when we start to say, okay, this person is not compliant in any way. So we're trying to be broad in how we're thinking about it. I mean, CAP is a very compliant different programs, but this is an opportunity to think about really using our touch points to be able to help folks. Or should we hold our questions to the end of the section?
What time do we want to finish this section?
If we want to, I think we should probably wrap it up.
Okay, yeah, I'm actually on my last slide.
Okay.
So I mean, one other thing I just want to say is that this is going to be a slow rollout. So we'll start with new applicants to CAP, and then we will, for current applicants, when they have their recertification, that's when we will be doing the screening and evaluation, and that happens every 6 months. So it's not going to be like on January 1st when this goes into effect, it's like we have a flood of people. It's going, we're going to learn as we go. And we are going to have this roll out. So in the first couple months, I think we're going to learn a lot about how this is going to operate. At this point, our intention is to contract out the drug treat assessments, both the initial screening, which we already actually partner with RAMS on doing the initial screening for our clients. But in terms of the additional assessments, the plan is to contract that out. It's going to be, complicated implementation, and we're going to be partnering with our other city departments, and we really want to partner with the community too, and have conversations about how to make this the best opportunity that we can given.
So that was my biggest question, is how can we as community be involved in implementation, providing input, and then more specifically this body right here.
Yeah.
But also a lot of us represent or work in, with organizations that work on behavioral health related issues. And so, how can our organizations and our, colleagues and such be involved in all of that? I have to note that the measure was drafted without that kind of input, both from folks like us, but also from even public health, professionals. And so I'm glad that you're working with DPH closely and that, they're involved now. But I want to make sure, there's that community component. And that there's like a real meaningful way for us who are working with these clients, and other aspects on the ground to help shape implementation, but also since we're going to kind of be seeing the impact, those folks will be in our programs and such, how we can be part of that feedback loop around how it's going, you know.
Absolutely, absolutely. I think it's gonna be critically important because as I said, we're all gonna be running together these first couple months and we already are having conversations with folks around, what is the best way to engage the population, how to keep people motivated. The question rests, what constitutes compliance? What is engagement? These are not questions, it's not like we're trying to figure that out together and we welcome those with the input of you all that have the expertise. This is not our expertise, so I think this is one body in terms of being able to come and present and get feedback. We're happy to meet with people individually and, it's a question about should we set up some other separate advisory boards, specifically community involvement around this, that is really great, especially in our first year of implementation. So I appreciate the question and genuinely want to learn from you all in terms of how to do this in a way that seems to me and most effective.
So as a provider, I think to us, to me, to us, one of our biggest concerns is the protected health information that this brings up. I mean, this is very sensitive, protected health information, and this is not typically an appropriate. This doesn't typically constitute what is allowable, right, under protected HIPAA law, right? So it seems like this really calls into question potential for huge violations of HIPAA. And given how we we have a myriad of experiences with different workers there. Folks that are very easy to work with and folks who are at every turn cutting off our clients' benefits for unknown reason that doesn't happen in other situations that I think constitutes is indicative of their own personal biases against our clients, right? And so when we're already having difficulties with our clients who are in treatment or even getting, medication assisted treatment for their substance use problem that's at every time getting their benefits cut off, and someone who is has a long drawn out case for SSI, right? So he needs multiple. So, I mean, this is just one example. So what's going to happen now? And what amount of information? Because nothing that we give his current worker keeps him on benefits for more than 6 months at a time, then we're dealing with months of getting back on benefits. So I mean, just one, the HIPAA, and I think that how are we getting around that? How is that even working in this situation? It seems like this whole program is a violation of HIPAA. But I mean, and just the importance of it being very, very concrete. And then what are the mechanisms for workers to be able to quickly, then if we're running into these problems with folks for cutting off benefits for our clients, how are we quickly, not 3 months down the line, 4 months down the line, getting the benefits reinstated? That's what's going to happen, undoubtedly. If now, with less retirements, their benefits are constantly being cut off. And how are you getting around HIPAA with this?
Yeah, so let me answer a few of those with HIPAA. We don't need to know what their diagnosis is or what kind of treatment they're getting. All we need to know is that they are engaged in treatment. And so that's why part of why we also want to contract this out, right? Our workers are not going to be asking, did, Joey go to his, AA or NA? All we need to know is, did they engage this month? We don't need to know what that is. We don't need to know what their diagnosis is. So, one of the things that we're trying
they came to see us.
exactly. And one of the things we're trying to figure out is, do DPH, if we've selected a provider that's already kind of in the DPH system, they have access to Avatar, access to Epic, so that they can be the intermediary, right? They're already HIPAA certified, they're already Drug Medi-Cal certified, they already have access. And that's one of the things we're trying to figure out because there's going to be two ways. I mean, someone that we contract with could either have access to administrative data that can confirm, yes, they can stay this month, or they call the providers and they get a release from the client. And that's how, I know some pretrial diversion works is sort of a combination of the client to sign, have a record when you participated in it and get a copy of the sign-in sheet. And then they also have relations
So
with the
those,
providers.
those folks are pertinent.
Yeah, yeah, no, I understand that, but in their instance, they have a client sign the release if you're gonna contact the provider. So we're not, our eligibility workers are not gonna be doing that, they're just gonna know, did they comply or not this month? So that's one piece. I think in terms of, sometimes we have like a point of contact within a program where, you know, someone can, we're having issues in this area, like, you know, another completely different example, but with guaranteed income programs, there's a lot of guaranteed income programs now. We want to make sure that our eligibility workers understand how those interplay with benefits. So we have a point of contact within each program for GI programs. So we might do something similar where there's like a point of contact where people can call beyond the eligibility worker to say, hey, I'm having issues here. So that's something we can propose. That could be a good idea.
Or maybe, I mean, this is one suggestion. I mean, like, maybe you might have a liaison to particular, or like, to health ed, to CDY, to Felton, to like direct liaisons to some of these bigger service providers, and then we just work with that particular person around that.
Yeah, that's exactly what I mean by having a point of contact within CAC.
And then one last question.
Yeah.
So we have folks that are SSIP eligible, but they're not in SSIP because we're going through health ed. I mean, not through health ed, through PRC.
Yep. So there's a form that they sign that the provider, the SSIP provider signs, and then they submit that to the worker, and then that's how they confirm that every 6 months if they're still engaged. And then also on SSIP. So again, those folks wouldn't be required to participate in intervention. Or they did, but not required, wouldn't be expected. Yeah, no, good questions. And I think what would be most helpful, you know, hearing at a point of contact we think would be helpful, like hearing what would be helpful for you guys is what's really going to be instrumental for us in figuring this out.
I have so much to say, so I'm not gonna do that, but now, and I'm gonna connect with you. But just to leave you with this also, I think one of the, when I said the community, especially people who do treatment provision and service, you know, with folks on CAP and, you know, who have the public health experience, et cetera, would be very interested and concerned about in this implementation design is that issue of the definition of treatment. And particularly who are the, you know, who's providing that treatment, you know, because there's a lot of things that apply currently in that environment, you know, such as licensing and, you know, what's evidence-based, you know, practices, what the research has, you know, what's scientifically, you know, backed, et cetera. NA, for example, is not. So just to flag that, there are, there's, it's important to really have those folks who understand all of that involved in that conversation to make sure that we're not using taxpayer money to send people to, you know, treatment programs that really, you know, there's a lot of people who would call themselves treatment providers in all sorts of ways that, you know, unfortunately, we need to make sure that there's
Standards of care.
safety standards of care, yeah. And that, again, that it's, we're gonna get results, you know, from doing this, right? So,
Do you know providers that play this intermediary role that help connect people to a variety of treatment options? Because I think part of this, we would rely on someone with expertise, right? That could say, these are the best treatment options for this particular type of side.
Sorry, you guys.
Yeah,
If we are gonna
yes.
do,
well, let me just say though, there are providers who within, you know, their services provide a range. Right. And so, you know, maybe that's partly one of the things to think about is like, they have kind of a whole bunch in-house that, you know, so there's a difference between what they kind of need in terms of, do they need MAP versus do they need residential? And then this other issue of like, what type of approach, you know, what model of treatment? Is it, you know, abstinence-based, is it harm reduction, is it, you know,
Will you be providing?
recovery model, is it, you know, that's a whole different sort of thing, so.
Like, will you be providing any data of like what? Actually, outcomes from this?
Yes.
Yeah, and we definitely would
And
want
that's
to.
my unit, I would, planning policy, public affairs, something design, that's
Sorry.
that's
I think Valerie's gonna explode it.
Yes.
I just.
I know, and I gave that
I don't,
caveat.
I have a process question, and that is, how do we engage on this
Us.
prospectively? And whether we
Yeah.
have a subcommittee that needs to be periodic, or whether we come back in 2-3 months. But we need to figure out what that is, and I'll defer to the rest of us.
Yeah, and I'm happy to,
We
yeah,
can-
yeah.
we can be in
Hillary
touch
and Sean will
and,
figure out. And then last thing I'll say, and then I will cede, I mean, we've talked to Hillary about funding a position within TAP that could play, the role of just helping to connect, right? So I think we're trying to figure out what is the best, we want the expertise and we want to figure out access and, that could be one way of doing it. So
Can I make one short sentence and then I'll turn us over to Jessica, for Prop One, which will be equally, scintillating. This is a little bit to Sarah in conceptualizing what we mean by treatment.
Yeah.
I just want to encourage this group and us to think about it in perhaps a slightly different way than we might think about people coming into care without a mandate. Meaning, I've urged HSA to think about treatment as broadly as possible. So lots of things found
I see.
such that the person is as likely as possible to have their benefits continue. And to acknowledge that this audience are not necessarily treatment-seeking folks who might be ready to sign up
You're
for
right.
kind of an all-in, I'm ready to get to work on all of my substance use, and instead design a program that is more flexible for all the folks who might be coming in who have much more ambivalence at the moment, to try to set it up so that, as we know, people who keep coming back are more likely to be successful with behavior change than people who don't keep coming back. And so to create the conditions and flexibility instead of it's like this intense treatment program or nothing.
Thanks for that reframe. That makes more sense in this context, yeah.
So in this
Yeah,
context, this
yes,
may not
exactly.
be
I used to a
other
different
context,
Yeah.
which I
Yeah.
very much.
Yeah.
And so I think this is what HSA, I mean, as I think you've heard from Susie and her team is striving for, and with, I think we are in alignment there. So.
I just want to acknowledge Steve Fields. I know you have your hand up. We need to move on because these folks have a very hard stop at 10, so we'll take the questions after they're done. But we do see your hand.
With all due respect, I
Okay.
think we have to let Susie go as
Yeah.
well. So we may have to save some questions for
Yeah.
a follow-up offline, things like that. But I want to, just while we have Director Brown here, I want to get a second on Prop One before folks need to leave. And I think as far as SB 43, we did prepare slides. Dr. Pennins needs to leave at 10 as well. So what we can do is bring SB 43 to the next meeting.
You can send out, you have the slides, you
Yeah.
can also take questions offline.
Yeah.
And we'll come back.
So. and I
Valerie,
apologize.
I wonder if my hand's up for a reason, but I can barely hear people talking. I may
Okay,
very
sorry,
loud.
Sorry, Steve.
I think I'm gonna leave the meeting because I can't hear 50% of what people
you
are
put 'em on
saying.
the
It's
phone?
a-
He's the fourth.
Well, hold on, wait, can you wait for a second, Steve? We're gonna try to fix this because it's important that everybody hears. So we're gonna have people
Yeah.
talking. We turned
We all,
him.
we all have work to do. Yeah, thank you.
Let's see. And we have the little pods.
We're gonna put this in front of Jessica.
Mhm.
And then anybody who's online, so Jen and Kaylee also, please jump up and down if you can't hear.
Yes, Haley, could you jump to 16, please?
I think this is slide 16.
No, then next, if you could go forward, please, or back, sorry. Sorry, back.
Yeah.
You're back in this.
Oh.
Thank you, Steve.
That might help.
I know, but I haven't had any interest yet. It's a lot of things to try and cover in what, less than 3 hours. Then we started late.
Yeah.
Yeah, I did it. Good something, huh?
For a minute.
And I think this
Give
all,
it back further, please.
what, is it the prop, MHSA, the
It's
prop one?
prop one.
Okay, slide 8, Haley. And I think this is actually also a speaker, so it's odd, but you need to speak this way so people can hear. So it's not looking at each other, but looking that way.
You don't want me to go, maybe
No,
I'll
this
stand
one.
over there?
Yeah, I want to switch places?
Yeah, I can.
Yeah.
Here's-
Big fun picking up that.
Thank you.
I don't think it's plugged in. This is missing something here.
Somebody came in
Yeah.
and unplugged
Yeah.
I'm sorry.
Okay.
No, this is other duties as assigned.
I know, job descriptions.
Okay.
She was already crawling around a lot today.
Yes, we'll try to troubleshoot, but let's listen to Jessica,
Okay.
please.
Okay, I'll try to be quick, but I'm happy to also come back, if there's more questions and less time. Next slide, please. Okay, so as Hillary mentioned, I manage the Mental Health Services Act, and all you all know that, Proposition 1 passed last week, which really changes the dynamics of the Mental Health Services Act. So I'll just go through a little bit of the background real quickly, and then get into what the new changes mean and what our strategy is as a department to address these changes. So MHSA, now known as the Behavioral Health Services Act, was enacted into law in 2005. And what it did was take a 1% of tax income over, of those personal incomes over $1 million to help transform mental health services. So all counties throughout California receive a certain allocated amount from the state each month, each year to do more innovative, transformational mental health services that really meet the unmet need of our vulnerable populations. And so it's based off a set of core principles. One of those principles is providing wraparound services, culturally responsive services, and also looking into the workforce, making sure that our workforce is reflecting the communities that we're serving. Next slide, please. Okay, so initially how MHSA was developed is that we have 5 funding categories. The first category is community services and support, which really focuses more on our traditional mental health services such as full service partnerships, also intensive case management. The second category is the innovations, which looks into new innovative ways to engage and link clients into care. Looking at how we can, again, have culturally responsive care for our communities. Prevention and early intervention, that focuses on population-focused programs, also looking at school-based prevention and early intervention, stigma reduction programs. Then we have our workforce education and training, which again focuses on how to increase clinicians into behavioral health services and provide any workforce or education to existing behavioral health staff. And then capital facilities and technology needs, which looks into renovations, how to help expand our clinics and how to make them more welcoming for our clients, as well as the use of technology as well. So San Francisco is a bit unique because even though we have 5 state mandated categories, components, we have 7 funding categories. So community services supports not only has traditional mental health services, but we also have vocational services, peer support services, and also housing. So our goal was to really make sure that we're providing a wraparound approach, holistic approach to meeting clients' needs when they're entering our system, even if they're in a full service partnership. And then we have our housing, workforce development, capital facilities, and our mental health promotion, which is our prevention and early intervention. Next slide. So with Prop 1, formerly known as SB 326, it takes our 5 funding categories and it makes them into 3. So the goal is to really help modernize the Mental Health Services Act, ensure that we are focusing our efforts on housing, expanding our full partnership services, and also including substance use,
And then also supporting what the new category will be behavioral health services and support. Next slide, please. So again, this is just the overall reason for the reform. Really to focus on meeting the most vulnerable unmet needs, looking into implementing a multi-year implementation strategy starting in 2025. So this act, even though it passed, it will go into effect January 2025. And then also to really update our local category services and supports to meet the current need, which is housing and substance use services. Next slide, please. So these are now the new funding categories. So instead of, again, we had 5 initially, now we have 3. The first one will be housing interventions, which will be about 30% of our funds will go into housing. This is looking into various different components of housing, whether that's rental subsidies, operating subsidies, housing vouchers, those types of things, or even expanding our current housing units that we have under MHSA to 101 units with HSH. The other one is putting 35% into full partnerships. So really ensuring that we're including co-occurring disorders and accounting for substance use treatment as well. So 35% of our budget will go into that. And then the next funding category is our behavioral health supported services and support, which will now include prevention, early intervention, workforce, innovation, capital facilities, also our prudent reserves and any behavioral health pilot programs with the innovation. And so this is now, like I said, we're going down from five to now 3. Next slide. Okay, that was a quick overview. Straight to the point, thank you. So what our response right now is, as you all have seen the mayor's response to Prop 1, we are currently working on a strategy with other city departments on how to implement Prop 1, especially as we want to make sure that we are preserving our population-focused programs. And so really thinking about how to build a strategy with them over the course of the next 9 months before January, we'll be meeting a lot of our population-focused programs to ensure that they understand and can strategize with us on how to meet the new requirements. So that's going to be our plan as a city. We also want to make sure that we're utilizing the again, sustain some of our incredible programs that are interesting that have been serving our populations over the last year. And then reaching out to our programs to get feedback and again, strategy on how to implement Prop 1. So.
And please include this as a body to do that.
Yes.
Sorry.
Absolutely.
Trying to do it.
So is there any current programs that we're getting, MHSA funding, are they, is their funding gonna be cut because of the restructuring? Are you anticipating any of that, or will everything remain funded that previously was funded through MHSA?
Yeah, we're still looking into that. We're looking still also from guidance from the state now that Prop 1 is passed, what that's going to look like. And then also we have a tool that we've used to kind of see what our scenarios will be if we were with putting in these new funding categories. So our goal is not to cut any programs. And so that's why we'll be meeting with our MHSA programs and other accountability bodies to think of a strategy so we don't have to make any cuts. So we have about 85 programs under the Mental Health Services Act. A few of them have, in the last couple of years, made a significant investment into local communities, including having more services for postpartum and pre and postpartum birthing people that need mental health. And so we want to figure out how to strategize to either support programs that may have housing components that we can help facilitate under this new initiative, or how we free up some of our PPI money for programs that may be not direct services, but maybe like consulting contracts that may be necessarily what we need at the moment. So we're just building out a strategy.
What's PEI stand for?
Oh, I'm sorry, prevention and early intervention. Yeah. I keep doing that, so I remind myself. Prevention and early intervention, yes.
Any other burning questions? I want to be respectful of the hard stop that Dr. Pence and Dr. Brown.
And I am happy to come back. Once we have our plan developed, we can definitely come back to you all, get your feedback and advice on how to move forward.
We have a new wage.
Can I just say one
Oh,
thing
yeah.
before you leave? Just this came up when Jessica was presenting to our behavioral health commission. So there was public comment, which we weren't able to address, but a feeling of like, oh, this is this whole other thing, and is there duplication of services, and are the parts of the things talking to each other? And what I wanted, and obviously I'm saying this a little more casually than that moment, but it's all us on this side. So it's not that the programs live separate or aren't aware of each other's expansion. I feel like, remember, Wine, you have brought this up too. I
And I'm
just
still
wanna-
thinking.
But so when Jessica, Director Brown, referred to, for example, full service partnerships, which are ICM kind of plus, I'm looking at member Salinas. It's not that they're over here and then the ICM is over here. It's they're managed actually by the same program director. And in fact, we're trying to bring up, add money to some of the ICM work so that it can do some of the things that the FSP has been funded to, like for example, or when there's peer support being funded in one of our treatment programs, those are all working ideally in consort. I mean, sometimes there's programs that MHSA has been, frankly, a number of the prevention and early intervention programs where they're not Medi-Cal billable and where there has not been, MHSA really stepped into gaps in local general fund. But on the administrative and organizational side, it is all one, even though because of state requirements and funding requirements, it gets presented as if it's entirely separate. But that is because we are responsible, required by the state, rightly so, to track money and report on evaluation and so on. So I just want to leave you all with, at least that's our intent. And that is our organizational approach.
Yeah, and all of our intensive case management clients have access to these services as well. So if a client goes into our system, to Hillary's point, and they want to get job training or they need housing or they need peer support services, they have access to that. So we don't distinguish between you need to be a full service partnership, you need to be part, you need ICM. They all have access to all of our services. And I think one of our strongest points is that there are, with the PEI programs, there are a lot of CBOs in San Francisco that have already been doing culturally responsive care. And so as we're trying to also bring culturally responsive care within our system, it's partnering with them as well on different interventions to make sure that our clients are getting access to, again, innovation projects that look at lived experience and cultural value to help them with care as well. So making those partnerships not stronger, but making that connection to Hillary, as Hillary was saying, as making sure that our ICM FSP providers are also seeing clients that maybe our CBOs are seeing, and also linking each other to different services.
All right, we have a conflict. And
Oh,
you know,
yes.
I'm sorry, we're running out. I'm sorry, we started late.
Thank you all.
Thank you.
Thank you.
Thank you.
Thank you, Susie, for coming.
Thank you.
That's great.
Is that your copy, Jess? Or no?
Oh, that's
okay,
fine.
yeah, okay.
Okay,
So,
before we move on, I think we should do a volume check.
yeah, well, I think we have to do public comment and then member fields, we're troubleshooting, the audio concerns. And so I think if after public comment, it'd be great to move
Yeah.
to breaks. We have a few minutes to work on that.
Yeah,
Okay.
and in general, that is the speaker that captures us. If you've ever been online, really, when people are speaking facing front, it's easiest to hear, which is odd because we're in the room, but if you want to be heard, face that way. So now,
So I just want, we'll get we'll fold the SB 43 into, was that a lot to try and cover, even if we had the full hour?
Yeah.
Three huge things.
Yeah.
Like that?
Yeah.
Okay.
So I think we're gonna have to carry it, what we can do is carry it forward to next month and also then be able to see if we can get others on the team like Angelica come for SB 43.
Yeah.
So, yes.
This is like whack-a-mole. We have many things to whack,
To make things.
and we don't have enough time to
Yeah.
whack.
Yeah.
And it, I don't know what role the chair is playing in terms of setting the agenda.
None so far.
We're all setting the agenda together the meeting before, so actually you all set the
And she
agenda.
sets the agenda.
Right, and we do
Under
that
the
at the last.
bylaws, the chair sets the
Yes.
agenda, and all I'm saying is that someone who's on this committee needs to have an input, because I think you have a better opportunity and a better understanding of how long things are gonna take. I think it was a good idea to try to introduce these topics, but every one of them could have been an hour long.
With perspective, we are trying to make time in the meeting for everybody to collaborate on
I
setting the
understand
agenda,
that.
which we did, and this was the request.
Yeah.
We are trying to honor that
No,
request.
I just think, we don't have enough time,
Okay.
and we need to figure out how.
Well,
better
it's
to spend
partly
this.
our time and it's partly coordinating with people who are coming. And so I think, I agree. I mean, it's partly starting on time too. So when we get to the agenda item later on about setting the agenda, that's why we've been trying to have fewer. And so maybe and that's also why we're putting all this administrative stuff at the end. But I mean, like, it's always gonna be, I think it's a lot. So we just have to be aware. Public comment. So Valerie, can you refresh the members of the public attendees? So members of the public who wish to provide comment on the director's update. There's nobody here in person, so I'll call on anybody who's joining us online. If you would like to make a public comment, please raise your online hand and we will unmute you and you will have 2 minutes to make your comments. Let me get this again so I can refresh. I don't see any hands raised. So Chair, I would suggest that we close public comment.
So hearing no further callers, public comment is now closed.
And I think Valerie wanted to take the break now and do roll call after so we could figure out the sound stuff.
And, okay, so we'll do roll call after.
I mean, is that's your all's call for the roll call.
I think it would be good to be able, if Steve Fields is still around, to try and figure out the sound.
Yes.
So, let's break right now and see if we can figure out the sound. Is that the folks here from the controllers?
But not the controllers, no, it's from facilities. So
Oh, from facilities.
Yes.
Okay, great. Then have it, and then the controllers will be here shortly also.
At
as they're-
10:30-ish.
Okay,
But that'll be fine. If we do like a 5-minute break now, and
okay,
then we could do the roll call and all of that stuff. And then,
and the meeting minutes.
yes.
Okay.
So we
great.
come
Let's
back,
take
we'll
a
be on
break.
slide 24.
Thanks.
So people online, the facilities people are here to help us troubleshoot the sound, and we're taking a break now.
Thank you, guys. Okay, so here's members in here. So I don't know.
Yeah, these little pod
Seems
things
like
don't
they're
seem
all plugged
to
in.
do anything.
Goes path to nowhere.
And then there's these silver things that showed up, and we don't know what they
Yeah.
are either.
This
Do you wanna
doesn't
feed this?
doesn't belong to this. It doesn't belong to that, no.
You want to feed this through the,
We're not doing anything through this.
Okay, so when I came,
It's
it's
just
somebody
a-
disconnect.
but this is all good here?
These are, well, I mean, we don't know if there's something that shouldn't be, because I'm not sure. But
I mean, the people can see, it's just, and you can hear a little bit, just not very
These, see
loud.
these microphone pods here?
It's the microphone.
This is what the cord is going to nothing. So obviously.
He's here.
That one just plugged into the other one. Right here.
Oh, does this?
This one just plugs into this.
There's 2 cords on that one.
Right.
Here.
Yeah.
Is there?
It's just gonna plug into each other, yeah?
Does it need to be?
I don't know, but then where does that?
Good mic, yeah.
But I think you're just doing a continuous loop down.
I have no idea.
Seriously,
We'll try to get Bill or Mike from IT, because this is IT.
Bill, I don't know who Bill or Mike are. I don't know who Bill or Mike are, is that? what are their last names? so that I
Yeah.
can reach them?
Bill Nye didn't.
Sorry, you called it, we're in a public meeting and we need, the sound is super important for the public meeting.
Bill Callahan?
Different
If you have contact.
Really?
Yeah.
I'll get him, then, part of this one.
Oh, okay.
To get him.
Thank you, I appreciate it.
How many years?
How long, like 2? Oh, yeah. It's
Yeah.
gonna be pretty wild.
And I think this has been going, I mean, yeah, this is good.
It was dark a little bit before he got here.
Oh,
So,
really?
yeah. He's been good, you're right, but see how long he holds out. But yes, he's a very cuddly guy.
Do I need to let anyone?
Yeah, he's very friendly.
I think so, yeah, or they got the,
Oh, he actually lived with a guy who lived on the street. Yeah. On the sidewalk.
What happened to him?
He ended up passing away. Yeah, it's a little tragic story. But yeah.
And you picked him up.
But we hung out, even when he was still alive and stuff, and then she wouldn't do until that, we would take care of him. Yeah.
Okay.
Yeah.
yep,
Maybe.
yep.
I guess so.
Yes.
Yeah, I guess so.
Is everyone back? Okay.
Is
And so
that Michael?
we can bring it over there.
Presume it's the-
Yes, I'm unmuting us to bring us back. I'm saying for the group to speak slowly, to say who you are before you speak, and then to speak one at a time, and that seems to be what works best for the people who are joining online. And again, anybody who's joining us online, if at any time you can't hear us, please like wave your arms wildly and, you know, unmute yourself and.
You can also text me, but we are bringing, we're getting some IT folks to come up and verify that everything's connected okay. And I apologize for the audio difficulties. We actually don't have any visual indicator of whether these are connected or not. They don't change color or anything, so we just did not see the difference. So as soon as an IT person can be here, they will. In the meantime, we're going to speak loudly and slowly and do our best here. So,
And one at a time.
yes.
Great, so should we do roll call now or
I
should
think
we
that's,
move
that's
to?
just what we have Wendy here. We can
Okay.
go ahead.
So that is line, I guess we should ask the group.
I mean, really, I mean, I think that since, I think that we should do the minor things, hoping to get the sound fixed.
Okay.
So that Steve can
Okay.
hear.
Okay.
Um,
I don't have a timeline on how soon someone can come assist us, but
Well,
I
Steve, can
appreciate
I help us hear us right now still?
is there any, do you guys have?
We've been-
Jen and Kaylee and Steve, can you all hear us at this point? Okay, yes. We don't, those, we don't know is the short answer because it doesn't light up or anything.
Hello? It won't indicate.
It doesn't indicate.
Yeah.
Mic check.
Yeah, Jen, do you hear that? When they're saying
Yeah,
check?
so Jen hears.
But we don't think that it's necessarily because of those squares. It's just because I think the front speaker is picking us up.
Oh, okay, so then why do we need to
Okay.
fix those squares?
Okay, so then,
We just don't know.
Yeah, yes, thank you.
Okay.
We would love to have
I know.
something on the table that is a speaker. Right now, we don't know if we have that or not. We do know we have that very front speaker.
Right, but what matters is whether people can hear. us.
Yes, and Jen can hear us.
Right, so then.
Yeah, so just to verbalize, like we can hear things okay. It's when people are talking at the same time, like even if you're agreeing with one another, it create, like in doing that group, when you're in a group conversation, it just muddles the sound and you can't hear it. And then for speakers, if they don't introduce themselves, we don't know who it is. So it's just kind of to keep those things in mind.
okay, can we do the roll call though? Because I think we
Yes.
should establish quorum, which is what we should do at the beginning.
Yes.
So, okay, so let's do roll call.
Okay. So roll call will now be taken to establish quorum. When I call your name, please say here or present or some other verbal way to indicate that you are here. Member Fields,
Here.
Member Gonzalez,
Here.
Member Lipton,
Here.
Member McGuigan.
Here.
Member Patterson texted that he is ill and will not be joining us. Member Salinas.
Here.
Member Short.
Here.
Member Wong.
Here.
So we have 7 out of 8 members, so the quorum is 7, so we do have a quorum to continue. So next slide, please, Kaylee. So per IWG bylaws, the IWG must vote to excuse absent members. If the working group does not take such a vote at the meeting or a previous meeting, then the minutes shall note that an absence is unexcused. Any member who misses 3 regular meetings within 12 months without the express approval of the IWG will be deemed to have resigned within 10 days after the 3rd unapproved absence. So Member Patterson has submitted a request for an excused absence. Chair, is there any discussion before we vote?
Do we need to discuss? No. No, let's move to a vote, please.
Okay, so I will now call roll and ask each member to vote yes or no to excuse Member Patterson. Member Fields,
Yes.
Member Gonzalez,
Yes.
Member Lipton,
Yes.
Member McGuigan.
Yeah.
Member Salinas,
Yes.
Member Short,
Yes.
Member Wong.
Yes.
So we have 7 yeses and 0 nos. We have a majority to excuse Member Patterson.
Okay,
Back to you, Chair.
so do we want to skip the approving the minutes to move to the wage and staffing Okay,
Yeah.
as you are ready. So
Let's do
let's
that.
move to,
Slide 30, please.
so we are moving to discussion item number 3, an update about staffing and wages. For this presentation, we are joined by Wendy Lee from the Controller's Office. Thank you, Wendy.
Thank you, everyone, and good morning. Thank you for the opportunity to come present to you all here.
Finally, right?
Please let me know. Yes, thank you. I know it's been a while since we've had a chance to come talk to you all. Probably the last time we did, we were still all in a virtual environment. So it's really, thank you for the opportunity to come meet you all here in person. So the goal today, and can we go to the next slide, please? Because it's been a while, we want to take this opportunity to reorient to our staffing analysis, review the findings that have come up from the staffing analysis thus far, and we want to hear your input, questions on those findings, as well as hear your input on the framing and the approach for the strategies that we are putting together based on stakeholder input and what we hear from you all today. And then we will wrap up with our next steps and be able to talk through what to expect next. So as a reminder, because it's been a while, the objectives of the staffing analysis are to do a really focused, targeted staffing gap analysis, looking at what is happening now in the status quo system. The goal here that we set out to do is to identify what are the worst service bottlenecks in the current system based on the data that is available in our current state, and to really dive deeper on what are the root causes of known staffing challenges, which are probably not surprising to any folks here in this room. But the goal here is to dive deeper and try to come up with some targeted strategies in order to try to move the needle on this in the short to medium term. Next slide, please. And so in order to do this targeted staffing gap analysis, the overarching approach that we've taken, or we've plan to take, is to one, start with identifying where are there staffing gaps. I know there's a lot of words on the slides, but I think the way that I sum this up is really the key questions are, one, where are there staffing gaps? Number two, why do those staffing gaps exist? And number three, what can we do about these most significant staffing gaps? And on the slide, you'll see a little more about specific project activities that lined up to try to answer these questions and the specific sub-questions that we hope to answer. Next slide. And I think I'm reading through some of these, you've seen some of these, but please stop me if at any point you want to dive deeper into these. There's plenty of opportunities throughout to do this. So touching back on the last time that I got to talk to you all here, when we last came to you all, we were really just starting this staffing analysis, thinking about what is the approach, who are the positions that we want to focus on. And then from those early scoping conversations, what we had heard was, hey, like licensed clinicians, behavioral health clinicians seem to be really where the gap is. And that's what we came to this group with. You all have shared and given us feedback that it's important to not only look at licensed providers, but also non-licensed case managers and counselors in both the city and CBO provider setting. So we went ahead and broadened our approach to not only look at licensed clinicians, staffing challenges there, but to also look at non-licensed case manager and counselor roles as well. Anything from the last conversation, you all had shared that it'd be important to look at differences in wages. What are those qualifying experiences for licensed and non-licensed roles, and what kind of positions and like roles and responsibilities those positions have, and to also look at barriers for hiring and retaining peers and those with lived experience. Next slide, please. So since we last got to meet with you all, I wanted to share an update on what we have been up to. And so moving on the slide, moving from left to right, I want to orient you to what the activities that we did to try to understand what are the staffing gaps and challenges among city providers, among the CBO providers, and across the behavioral health sector. So In looking at city staffing, we worked with DHR to review human resources data on vacancy rates, salaries, promotions, resignation data. Interviewed system of care and clinic directors. Also interviewed the human resources and operations team from BHS, and also interviewed the employee experience and the JEDI team, as well as the SEIU local 1021 contacts as well. Among CBO providers, we analyzed salary and vacancy data that was drawn from the Controller's Office nonprofit wage and equity survey that was done in 2022. We interviewed 12 CBO providers that have a range of behavioral health services, populations, and neighborhoods served to understand more about what their experiences are. And we've reviewed the Northern California Fair Pay nonprofit compensation report to try to give us a sense of how nonprofit what that wage benchmarking looks like.
Sorry, Valerie, should we pause to fix sound stuff?
Okay.
Okay,
No,
no,
no.
sorry, Wendy.
No,
Continue, please.
You guys continue, don't
So
mind me.
they are hearing from the front, but not.
Not from any of the things on the table.
The microphone pods don't seem to be. So, excuse me.
No, that's okay. So continuing on, and so those were the deep dive to look at CBO and city providers here in San Francisco. We know that what's happening here in San Francisco is not happening in isolation. So we wanted to also look at what's happening across the behavioral health sector. So we looked and referenced reports from the National Council for Mental Wellbeing, National Council of Nonprofits, Health Force Center, ECSF, Kaiser Family Foundation, and the County Behavioral Health Directors Association of California. So this was a review of assessments and reports that these groups have put forth. I'll pause. I wanted to ask what questions do you all have about this methodology?
And I see a hand from Member Fields.
Right, the other days, Member Fields.
Thank you for this ongoing report. I think it's one of the most important things we're doing right now. I just wanted to mention, and I think your outreach to the CBOs in particular, where I think the biggest salary discrepancies, not only amongst categories, but between the CBOs and the city is demonstrably has to be addressed. But I do want to mention something. SEIU 10-1 also organizes CBO workers. So their point of view on city provider issues is one thing, but some of the largest CBOs are unionized under 10-1 as well. So you might want to, it'd be interesting to me to broaden the discussion also with them to see what their advocacy is for the members that are making less money on the CBO side than on the city side. So I want to make that a part of the deal. Their input on the status of the salary discrepancies for CBOs would be important also.
Thank you, Member Fields. Because SEIU also represents many CBO providers, that getting their input not only on what the needs are on city providers, but also CBO providers is important. So thank you for flagging that. So there are other questions from the group about the approach, and are there other data sources that we suggest we review or consider trying to align with?
Are you gonna go through later what the so we got these slides yesterday to get a chance to look at the what the differences are for like the city providers and CBOs and what the deltas and gaps are?
We're gonna have some of the preliminary data on the vacancy rate data, and the wage data. We're doing a little more validation. So that will be coming. So we'll share the data that we have, and there's definitely more to come. So this is not data that we're gonna go over, and there's gonna be more.
Okay, it's just
But the data that you're reporting on today is just the BHS data. Because this was a great, right? There was a larger of all the CBOs, but this is specific to BPH or behavioral service, which
Yes, specific to BHS, behavioral health services specifically. So really focus on it. The broader set of the data that Controller's Office nonprofit wage and equity survey was a much bigger pool. I think it was like 152 nonprofits that represented a much broader sampling. And we drilled down into like a specific subset that have.
So you have the numbers for the CBOs and the how many CBO providers is this in this category?
In this category, it's 9. Yeah. Yes. 9 for the wage vacancy data and interviews for 12.
Okay, that's right.
Not a one-to-one, but we did a broader because they were different efforts. Did a deeper dive. Some of the CBOs that we interviewed were ones that participated in the survey, and there were others that we brought in with this group's input as well on who else to include. To the next slide.
The slide controller is somebody.
Thank you. Next slide, please. Okay. Sorry. No, thank you.
Stage voice.
Keep reminding me, it's super very helpful. So we did a crosswalk of the behavioral health roles, the licensed clinician, non-licensed clinician. This was in response to feedback from our last discussion where y'all shared it would be helpful to look at a crosswalk between how these roles compare between licensed and non-licensed providers, but themselves as well as those roles, as well as and how that lines up with how the city and CBOs seem to be using these roles. So looking first at non-licensed caseworkers and counselors, where the city uses health workers ones and twos, seems to be analogous to where CBOs are using peer counselors. And these are individuals who may have lived experience. And these are folks who are providing support and guidance for these clients. Where the city is using health workers, threes and fours, seems to align with where CBOs are using case managers and non-licensed social workers. And from both our review of postings and conversations and interviews with CBOs, these seem to be for individuals who are in these roles, seem to be individuals who either have a bachelor's and or relevant experience. They play a key coordinating role, including working with clients to develop a care plan. And then what also came up in our conversations in our CBO interviews is it seems like also CBOs have residential counselor and substance use counselor positions. And these are ones that actually the city does not seem to have an analogous role for. And this is from our understanding that these are roles, these specialty substance use services are provided in San Francisco by key CBO partners. And specifically for the substance use counselor, this came up in interviews where a key qualification in California is that these individuals have a substance use counselor certification. So this is our attempt to crosswalk what these roles look like, the non-licensed roles in the city and CBO settings. Next slide, please. And doing the same exercise, looking at licensed clinicians. In the city role, this is not necessarily like a classification in the city's job system, but we know that there are behavioral health interns in both the city and CBO, among city and CBO providers. And these are individuals who are currently in graduate school and master's programs, typically in social worker counseling. And these are folks who are part of that pipeline for developing the behavioral health workforce. And where the city uses behavioral health clinicians, which is the 2930 classification, we understand that in CBOs, those seem to be often entry-level clinicians and therapists. And these are folks on the city side as well as the CBO side who have completed their master's programs and are registered with BBS, but don't necessarily have to have licensure. And then in the senior health, and then finally on the city side where there are senior behavioral health clinicians, which is the 2932 classification, that seems to align most closely within CBO setting for folks who are serving as clinic directors and clinical supervisors. And that seems to require an active behavioral health license and additional clinical experience. Oh, yes, Steve. Member Fields.
Okay. One thing that I would add to the final line, the senior behavioral health clinician on the CBO side, again, because it's unique on the CBO, world, residential treatment programs, program directors, as parallel, say, to clinic directors, are often and more increasingly it's requiring a senior behavioral health clinician to fill that role. So it's not just clinic directors on the CBO, it's also 24-hour residential treatment programs, use licensed clinicians in the role of a program director, senior leadership in each of the programs.
Thanks, Steve. I'm hearing
And the salary differential is huge. We keep losing people we've trained to the city. So I wanted to make sure it's understood that they're also now an important part of the Medi-Cal funding that goes with all of the 24-hour residential treatment settings.
Thank you for calling that out, Steve. I'm hearing that it's, well, in this slide, we've done the crosswalk and noted clinic directors. That it's important that, you know, that doesn't represent all care settings, specifically like 24/7 residential treatment settings is missing from here. Thanks for flagging.
Thank you.
Other questions, reactions? Okay, next slide, please. Okay. So on this slide are our vacancy rate data. So this is really our starting place. And we know that vacancy rates alone don't tell the full picture, but they are a helpful place, you know, to start digging a little deeper to see, you know, where are their staffing challenges. So this is really the data to help us answer that first question: where are their staffing gaps? And so you'll see to orient to the table. Thank you for zooming in there. Sorry, that's small. On the city side, in the city setting, the behavioral health clinician roles, 2930, have a vacancy rate of about 17.5%. Senior behavioral health clinicians about 18.7%. In analogous similar roles in the CBO setting, licensed behavioral health workers, there was a vacancy rate of around 18.7% as well. We have preliminary, because we're doing just another recheck of these to make sure these are accurate in terms of the exact numbers. And then the health in the city setting, on the health worker series, you'll see a range for a larger range from, you know, to anywhere from 2% to 29%. The number of associated FTEs for each of those is also much more variable too. On the CBO setting, we see that the non-licensed behavioral health workers have a vacancy rate about 12%. And the source of the data, just to orient for the city vacancy rates, are from the city's PeopleSoft data, which is our internal city system on vacancies, wages, positions. And then the source of data for CBOs these are the subset of the CBOs that participated in the Comptroller's Office Nonprofit Wage and Equity Survey, where we had that fuller set of data on their wage and vacancy data. So this does not represent all CBOs that have contracts with DHS.
That was one of my questions.
Okay.
Given it says there are 9 surveyed CBOs, do you think this is fairly representative of CBOs as a whole? Or is this either potentially under or over
Yeah.
what the actual rates are?
Yeah, I appreciate that question. I think, you know, this was a sampling, right, of data response. And I think maybe I'll answer that question with a question I'm curious to open up for discussion, that for you all who work in the CBO setting, how do these vacancy rates compare with your experience?
Well, I guess kind of walk up just a bit, which are the CBOs that you surveyed?
Yeah, good question. I can pull it up on a list. I don't have them off the top of my head right now. But the ones represented here include, I think, Rams, Source to Plowshare, Big Health Right, and so I can follow up with the full exact list. But these were chosen as the full 152. So this came from the Comptroller's Office Nonprofit Wage and Equity Survey. That was 152 nonprofits. And those were designed selected to be like as big of a sampling and try to be representative of the nonprofit sector. And for those, we drew from that and just focused in on just the ones that did respond and had contracts with VHS. I don't know if that helps answer your question and what new questions that.
Yeah, I mean, I think it does matter, like what, I mean, because there's very large organizations, right? Health Right is one, Progress is another. I'm sure actually Citywide did also respond, so, but, like Felton, there's like, is this sample representative of the target, who's working with also the target population of mental health staff, right? And how many clients are they actually working with? I mean, if it's a very small organization, versus, large, somebody who's serving 1,000 clients versus someone who's only serving 200, right? I mean, and how many staff do they have, right? I mean, that's the thing, right? If it's an organization that's only staff with 30 people versus one that's got 200 staff, right? I mean, that really affects like what we're looking at, right? As far as staffing, like how many folks are they serving and how much staff do they actually, so how much staff of the workforce does this survey actually represent?
Yeah. That's helpful. I don't have that off the top of my head, but I'm jotting that down as far as like coming back with kind of what are those lists just to be able, or we can involve in between with the list of those nonprofits. I'm hearing characterizations of what is the size of that organization in terms of their staffing, perhaps the size of their contracts with EHS, and the number of kind of clients and staff.
Steve has his hand.
Yes.
Steve, you have your hand up again?
Oh, yeah, I do again. I'm sorry. There may be a slide later on in this, Wendy, but I wanted to put in place the other discussion, which is the consequence of vacancy rates in different modalities. Those services that scope for case management, outpatient services, may end up with a larger caseload, or they may actually stop intakes for people who need the services. But 24-hour programs that are sustaining a certain vacancy rate could have to close temporarily because they can't meet licensing and Medi-Cal staffing requirements. In other words, a 24-hour program can't serve less residents because they have 3 openings on their staff. So there's that whole consequence model between modalities that I hope is part of the analysis, because there have been, over the last year, at least 3 residential treatment programs that have not been open because they could not staff. And even 2 people can put a position, could put an organization in a position of having to temporarily close because they can't meet Medi-Cal requirements and licensing requirements for 24-hour coverage. So 12% in a 24-hour program could be more impactful on that ability of the program to stay open than a 20% might be on a scoping service that can scope up and scope down. And I hope that analysis becomes part of the report.
Yeah. Steve, thank you for noting that. I think, let me go back to the data to just reconfirm the level of detail that we have in the quantitative survey data to just suss out the degree to which we can or can't assess that. But I think, Steve, that point is well taken. It definitely did come up in qualitatively. So I think there's that, we're taking an approach of trying to use the quantitative data where we can. And then also there are going to be lots of places where we're drawing on qualitative inputs. But Steve, that point is well taken.
Thank you.
This Steve has a question.
We both have to give. This is really is important data. We get to vacancy rates. Is there any way to get more real-time data so you can see trends? I mean, if I understand this correctly, and maybe I'm wrong, but the VHS data is about 9 months old at this point. And the CBO data looks like it's more like, what, about 18 months?
Fall of 2022, so probably about a year.
You know, is there any way to get more from those who are participating, particularly the CBOs? Is there a way to get more real-time data? So to see whether or not things are getting better or getting worse.
Yeah, I can speak to, at least on the, I'll start with folks, I think, see if I'm comparing, just given the time points of these data, that it's been a while. Is there a way to not only get updated data, but maybe be able to look at different time points to understand how, if at all, this is changing, right? Because what we're looking at here are just point in time snapshots. For the vacancy rates among the VHS positions, the city positions, we're able to get more up to date because we have an internal data system to be able to get the snapshots. We did look at a few time points and those are relatively stable, but I can work with our DHR partners to see if we're able to get updated data on that. On the CBO vacancy rate, these were done as a one-time survey. I mean, I think what I'd be curious from folks on this call is, I think, how do these maybe seem to compare with what you've experienced in your work? I think right now we don't have a plan to re-administer the survey at this point right now. So it would be interesting to hear for folks on this call how these rates have changed, resonate. And on the flip side, how have you all seen vacancy rates change in your work maybe over the past year?
I mean, I'm curious about, I expected there to be greater disparities between the VHS vacancy rates for the licensed and
non-licensed?
So the non-licensed are the equivalent of the health workers, right? And so it's interesting. So I think that I'm most curious about the license level because we lose a lot of work. We lose a lot of those licensed staff too, among all the CBOs. So it's very curious to me that despite losing so much of our staff to the city, and something also that Steve referred to, that once he gets licensed staff, they're going to the city. I think also even to some of the CBOs on their part, but that it's the same. That's very kind of baffling to me. It's just a little bit less, right? Behavioral health clinicians are licensed, right? That first category. And so it's virtually the same. That's really curious to me. It kind of almost, it doesn't make sense. But that's also, given, I mean, what does that say, given that VHS pays more, right? That's why we lose staff to VHS, because they pay more. And nonetheless, if they still have that rate of vacancy, what is that about? And then that, and then it's also interesting, this discrepancy between the lowest level health workers having such a low, like you would expect that they would be moving up and getting paid more and then staying, right? What's happening there, that they're not with the non-licensed health workers. The BA level or less health workers. Because I'm sure that those workers are also getting paid significantly more than a lot of the peer staff that are working at the CBOs, and particularly at all the SUD programs, right? You get paid very. So, I mean, so this includes are there any SUD programs in this, like CBO, like Salvation Army?
Yes.
Yes, you do, yeah. I mean, and if not, like, just to think about that, right? I mean,
as far as the CBO vacancy rates and whether they represent, like, who, it goes back to that question of who is in the sampling and are there folks who are delivering substance use services. So we can definitely go back and pull out who are the folks who are represented here and be able to characterize, at least based on the information we have, bring it back to you all. on
Yeah,
are
because
these
of the
folks who-
the bigger study, right, the lower could also put, I mean, it raises, GI questions, right? Because a lot of the lower, there's overrepresentation of BIPOC folks in those positions that don't require college educations, right? I mean, there's some, and then there's huge disparities, right, in wages, right? And they're getting, they're below the AMI, right, way below the AMI. And so how are we addressing those things,
I do want to note on that.
Oh,
I know it's fine. I just wanted to note on that part, if we have Director Brown come back, a number of our initiatives under JEDI are actually specifically aimed at licensed hiring among BIPOC folks, and that should be happy to talk about, I think.
And I guess, and then looking at how much of those the health worker, the non-licensed, and that are BIPOC.
Yeah,
as compared to, right.
I think they have some baseline data on that went into that, and there's some cool initiatives they're doing, like the lived experience pilot and stuff that I think she'd be happy to talk about more too, so I can flag that. Yeah.
Do we know the data on staff leaving CBOs once they're licensed and then coming to the city, like numbers, not like, oh, I think it's happening?
That's a great question. So no, the data that we have, we have not, at least so far, not that I'm aware of, we don't have the quantitative data. That very much was a theme that came up qualitatively, but to your question, like the numbers, we don't know.
And the other thing is just thinking, because it would
Getting
make
funny,
sense.
speak loudly.
Oh, sorry. Good. Okay, so, the other thing is like, if we know that that's happening, then our numbers should be better, they're not. The other challenge with, civil service hiring, and I don't know if, I think things are easier, more streamlined on the CBO side, is that we have all of these rules for hiring lists, like the hiring process can take forever, and I think people, they give up, they go somewhere else, and I'm wondering how much of that is happening as well, and that's why maybe our numbers are not as high as they should be.
Yeah, that's actually, I think you had a question.
Yeah, it's
before we move on. It's
related
Yeah.
to that. Thank you. I think that, our group would be most concerned with, well, we want to get these filled, overall, but with things like working conditions, salary, et cetera, being the reason why we're having great turnover or not able to recruit and hire or retain people, right? But there is sort of a distinction, especially when it comes to the issue of, is it that we're having a lot of turnover and it's a retention issue versus this recruiting people to fill vacancies issue? And that often can be related more to HR and some of the bureaucratic, issues that are happening rather than things that are more about the nature of the job, right? And so if there is a way to kind of parse out, a little bit which is which when you do the analysis, and I don't know how the best way to do that or if that's really very possible, but I know that especially in terms of that issue of filling vacancies, I mean, I've heard just time and time again that a lot of it is the Department of Human Resources, both and city overall, both sort of rules and policies and all that, but also slowness with which they operate and so I just think it would be important as much as possible to look, one, to not disregard that stuff, but also if there is a way to kind of look at, well, turnover is more likely to be about, and separate out what's more about we're having high turnover rates versus, or it's a retention issue versus a recruitment issue. And then even with recruitment, again, it's hard to know, is it about salary or is it, oh, we've got a lot of people who have applied, but actually getting someone in here is a different matter. Like trying to look at some of those more granular things to sort of see, I don't know how to do this, that's why we have you, but analysis stuff, but just if there are ways to get to some of that kind of stuff, I think it would be helpful.
I think I'm hearing like or to the extent that it's possible, kind of distinguish between recruitment, which is even getting folks in the door to apply versus like retention, which is we have the folks who are accepting the roles, but they're leaving, right?
Yeah, and then even within that category of recruitment, is it about getting good applicants or is it about getting people, like you're saying, getting people through that application process, into the jobs.
Yes. And I think, so no, thank you for all those. I think let's move to the next slide. And I think because some of the things that you all have lifted up as key questions, I think are going to start coming out.
One just last thing, I think one of the ways of ever measuring that, it seems like would be to interview actual, applicants at some point. To find out how that process, is it like you're saying, are there people who are leaving the pool even because they're so frustrated with the process or things like that?
Yeah.
Not saying that's within your.
No, but I think I'm hearing like that could be a strategy, right? The conversation is like lifting up things that are like, we probably know, or we either probably or do know that in the current state, that might not be part of it, but hearing that if it is a gap, is that an opportunity, especially given the staffing issues here, to at least test out to do that deeper dive.
And you don't have enough staff to do that.
So it's like two things. It's an exit interview from like people leaving, and it's a dropout interview. Like I started the process and HR, this is like molasses and it's taking forever. And so, whatever reasons they dropped out and where they ended up.
Right. That dropout
Would be
interview.
like a alternate that you sent like the whomever when they call them and they're like, no, no longer interested. They could just send them a quick question.
Survey. I think it's a great idea, like, and calling it like a drop, like a functional, we can, whatever the name is, the functional dropout interview.
Post application data.
And throw a chocolate bar there.
Post application, yes.
I want to do a quick time check. I've been informed, and Member Fields, correct me if I'm wrong, that he needs to leave at 11:30. We have about 20 minutes from when Wendy started to get the full hour on this, and then we would have to hurry other business along.
So we have 1, 2.
Yes, so just noting we would not be able to run over.
Okay, we'll run through these I'll run through this as efficiently as possible. So next here are some of the themes that have come up both through this interview. So we interviewed interviewed 12 CBOs as well as staff from BHS. And so through those conversations, what came through was that there's just we chunked the themes that we started hearing into things that were sector-wide. These were things that we heard across all interviews with CBO providers as well as city providers, as well as, and this lines up with what seems to be in the literature and assessments across the field as well. So again, probably not surprising to any of the folks here in this room, but sector-wide, so that a lot of these are fortunately not unique to San Francisco, that the behavioral health sector is dealing with lots of just sector-wide staffing challenges driven by just the growing demand for and need for these services, and therefore, the expansions of these services, the burnout, and this is already an issue pre-COVID that has definitely been exacerbated by COVID. Competition from other employers is something that came up in qualitative interviews as well. Though we know that we've heard among CBOs, it's competition from the city as well as other health systems. And even in the city, it can also be competitors from health systems or just other roles. And just grounding that in some national data. There was a survey done by the National Council for Mental Wellbeing, that self-reported survey data, but that almost half of staff have reported considering changing roles just due to workforce shortages and the burnout that's caused. And I imagine that's probably similar to what's happening here in San Francisco. Low compensation. And Steve, I see your hands up.
I just wanted to make sure that we should highlight what we're finding in our sector with a lot of other recruitment difficulties. It's actually the lack of healthcare benefits that's a major issue. It's even higher than the salary discrepancy when people come. So, and that's one of the biggest ones between our competitors, if it's the city and county, or increasingly for us, UCSF. They can offer family health care plans and coverage that's very attractive when the financial compensation on salary may not be all that competitive. But low compensation, I think we also have to highlight, because it's a national concern, more attractive healthcare options for employees is often a more popular issue for them than necessarily the salary.
To compensation kind of more broadly, not just what is my salary.
Yeah, it's true. When I came from, when I worked at Felton, the only health plan that was fully covered was Chinese health plan. And then we had we had Kaiser, had terrible options. But when I came to UC, I mean, it was like, you have like a menu of 20 different health insurances.
Yeah.
I mean, people pick, will pay, but there was no options at Felton.
Yeah, so it's not just the wages, but the healthcare options that are in place, that's helpful. Other ones that came up as across all interviews and that seem to be reflected in the sector overall were also just the documentation requirements and increase in telehealth, again, also especially after COVID. We heard both on the city and CBO side, as well as in some of these national reports or sector-wide reports that just the change in how services are delivered has really impacted how folks are coming to the role or whether they are or not seeking these roles in community behavioral health. We've also heard that there's been difficulty recruiting licensed professionals, especially staff that have the experience to work with specific populations, especially those that are the target population for mental health SF. Sector-wide, just not enough candidates for licensed clinician roles, and a declining pool of candidates for health worker and non-licensed physicians. And another contributing factor is just the lack of financial support for individuals who are trying to enter community behavioral health. So I'll pause there for a quick moment and wondering, I know Steve, you flagged the lack of healthcare options. Wanted to hear from the group which of these stand out to you the most and what other factors seem to be missing for sector-wide factors.
Yeah, I think, and we just don't get applicants a lot of the time, they're just not, it's slow to, I had positions open during the pandemic and was getting no, I think with a lot of, which was the case with several of my colleagues, we were getting no applicants sometimes for weeks or months. And then when we do get applicants, it's a much, and they have much less experience a lot of the time. And then I talk to them about what the job is and they're saying, no, thank you, so we definitely, it's like a pipeline, it's a trickle, and we definitely less experienced folks. So we're, and so we're really, we have a pretty robust training program. And so we're able to pull sometimes from there and sometimes not,
It's both the size of the pool itself is smaller, and for that pool you do have, it's folks that may be committed, may be interested, but are going to require a lot more investment and training to get them to a place to.
And then once they get their hours, then they leave to the city.
Yeah, thank you.
They're finding that a lot more too, once folks get there, whereas they used to stay, they go to the city.
Okay, next slide, please.
Or to the hospitals.
Or to the
hospitals.
Hospital specifically. So I think, so it started with that slide that we looked at previously, was like sector-wide. Those were the themes that we're, hearing both on city and CBO providers. And I think some of the questions that we're highlighting were like, well, that's interesting. Why is it a little different? Even the higher wages, like what's driving, what's behind some of these, what appear to be similar point in time vacancy rates. And also I wanted to parse that out a little bit, because even though there are high vacancies, there are some slight differences between what is driving vacancies on the city, among city providers, and what is driving vacancies among CBO providers under the umbrella of, I think, all the factors that we just looked at that are affecting this sector as a whole. So I think from looking at city hiring data and some interviews with folks in DHR and behavioral health operations, the factors that came up that bubbled up as far as why the high vacancy rate in amongst city roles is that there's been a big increase in the number of budgeted behavioral health staffing positions, in response to mental health stuff, as well as a lot of the other behavioral health initiatives that have come up, in the city, proxy, in response to the huge need for responding to overdoses. And so there's just been a huge increase, or there's been a sizable increase in the number of budgeted staff. So that itself is driving vacancy rate too, when there's just been a huge increase in positions. And I think this gets at the discussion earlier. What I think, Member Short, you were mentioning, well, what is recruitment versus retention? At least on the city side, with some of the preliminary data that we can bring. So this is high level themes that we can look at the data in greater detail together next time. But wanted just to lift those themes, which is there appears to be higher than average turnover on the city side among the behavioral health clinicians. So even though there's higher, there's actually
Higher than average, I'm sorry, compared to
Yeah, great question. Compared to even just the normal turnover rate in
of
the
other
city,
city.
other city
Okay,
employees
got
as
it.
well as other folks in the same union. So trying to do that comparison. So there's something, there appears to be something there around the behavioral health clinicians.
Yeah,
So this one,
I think we know.
yes. So it appears to be, this one, perhaps appears to be a retention challenge. Similarly though, compounded by it, and we can take a closer look at that data together, but in just the preliminary data, I think, Member Short, you're mentioning like, well, is it, this idea of exit interview, I think Member Salinas, you're saying, and also a dropout interview or a post, what did you say? Post-application chocolate bar survey is what I think I'm hearing. So I think from early data, it looks like there's also a low response rate from candidates who are, applying for a behavioral health clinician role. So I think it's a both end on the city side. Appears to be a recruitment and a retention issue.
Question, of the higher turnover rate, higher comparative turnover rates of city personnel,
Yes.
is that all city personnel or is that? What's that?
Compared to, right?
Yeah,
What is it
yeah,
compared to?
yeah,
Behavioral health clinicians
yeah, what's-
compared to what?
Yeah.
This is compared to behavioral health services as a whole.
Okay, so it would take into account those who work at the hospital and work at other areas. Okay, that's fine. All right. I just want to make sure we're talking about it.
Right, just have a little bit of a closer to apples.
We're getting closer to that. We weren't getting tangerines at first.
Fruit and vegetables and salads, right?
Yeah. It's a good salad.
If we have data, there's a way of getting data on the telecommuting privileges, like the different roles and whether we're seeing more people dropping out or not taking jobs that are 100% in person versus like, you gotta be in person 3 days a week, but 2 days you can telecommute.
So it's like, is there data on the telecommuting arrangements for some of these positions? Yeah. See if that data exists. I'm not sure if it does, but I think flag needs to be hard to do that data. Yes. But I think it's helpful to flag that as a consideration. And then also, so those are the behavioral health clinicians. And then among health workers, right, we saw that range from 2 to 29%. The data we saw was that what we looked at so far is that there's just been a lag in recruitment for health worker positions. So that's been a big contributor for why those vacancy rates were also so high. And I think some of the other themes that came up in interviews were the city's long time to hire, challenges with communication and coordination throughout the hiring process, limited capacity to host interns in clinical master's program. And then finally, as far as the city's requirement to have the BBS number requirement in order to apply for some of these positions. So.
Please go.
You go ahead.
I just wondered, is that not a general requirement in the more community-based programs? Because I thought it
Yeah.
was.
And that also is something we.
Just something. to look at.
Yeah.
Sorry.
Because the positions are meant for license, so you have to have your BBS.
Yeah, exactly.
Yeah. to be, or you have to be registered with the BBS, so you have to have a number to be able to be.
Right, so it usually applies though to
Sorry, not
both
licensed.
in the nonprofits and the city, right? It's across the board. Okay, anyway.
Yeah, to meet the requirements,
To meet the
you have to be BBS registered, not necessarily licensed. But I guess my question, so I guess the first bullet, so OCO, is it, so it was the Prop C money so we had a staffing increase of 45%. I'm sorry, I wrap my head.
From from looking at the data on positions, just over time, the number of positions has grown. I think it's
Like
like
45%.
I don't know that it's just from, we didn't look at funding sources from it, but I think this is just the overall the city number of positions in the city. So I think timing wise, probably a good amount of it could be driven by Prop C, but I think there's also other hiring initiatives for which like, the city has staffed up positions. So I think that is a big driver, and I think not the only driver.
So, and those positions though, is it direct service, or is it a range from that to administrative?
These were all,
Because there was a fair amount of administrative positions also.
these were all 2930. So these were all licensed clinicians. These were all behavioral health clinician positions.
So they're direct service. Direct service should be, yes.
A different range of services. We didn't look at kind of where it would didn't parse out. I don't know if that level data exists or not.
So the vacancy data might have been very different in the city because so this is, all of this generally was during the pandemic where hiring has been very hard. So the vacancy data might have looked very different in 2019 than it does now when there's all these added positions during the time that hiring has come across the board, to New Year's Day.
So needing to look at what that vacancy rate, like we had that point in time, but what did it look like leading up to it?
Like before the pandemic and before all these new positions that to be filled.
We can.
And I wonder how that impacted then not the CBOs, right? If CBOs have been suffering, these vacancy data were pre-pandemic, right? And so if the city didn't have these vacancy rates pre-pandemic, like how did it impact the CBOs over the last, 4 years, when all of a sudden also the city then starts hiring gazillion new positions when we were already down, does that make sense? When we were down nearly 20%, and in some cases, right? I mean, I'm sure that also varies for some orgs like Progress, or Belton, their vacancy data might actually be 25%, and organizations like Citywide, if they're counted right, we're skewing it a little more. So how does that, right? Because there's the things like the pension plans and whatnot that we can offer. Not to say though that, that's the way we can make up if but nonetheless, I think we're struggling, right? Because it's below, we didn't have, so we don't get to retain, we're not retaining anybody. We're training folks. We're a better option, say, than Belton or Rams or West Side, but then we're just training folks to then. And so what does that cost also for us in the long run, where we're constantly investing in training staff that are then just going to go over to the city or to, Sanford Medical Center, so what does that mean also, like, for us longitudinally? And without, and how did this and wave and new hires impact us all? The city's wave of new hires.
Like maybe two things, and correct me if I missed some of it.
Or maybe lots of.
Or more, maybe more. I think I'm hearing something around, data, which is, I think the Controller's Office, that survey was, done in fall 2022 is maybe a first or a more recent attempt to do a snapshot. And so I think, remember you were saying, like, is there more data to be able to, can we get updated data? And so I think there is perhaps a strategy or approach that you might not be able to do in this immediate timeframe, but it is a longer term, how is the city in working with CBOs to track this over time, right? On the city side, we have our HR data, but is there an opportunity to also kind of answer some of these questions, right? There's a point in time, but we don't have that complete pandemic snapshot. And, what does it look like now, right? Is there a way to be able to track that across the sector, right? Maybe different nonprofits are able to know internally what it is, but is there a way to pull that more broadly? So that could be, I think, an approach to really understand what the impacts of this is. This is, the first time that we're trying to look at this systematically, right? And then I think secondly, I think I heard, what are the impacts really given the investment in training upfront and that folks are leaving for other competitors? What does that mean for CBOs?
And then, they're constantly leaving and then you're short staffed again. And so then people are burnt out and, but then you have like a trickle of hires. And so it's like takes months to fill a spot. And, and so it's like a constant, like you never get to dry land. Okay.
I wanted to confirm the time check again, just member fields, is it, you have a hard stop at 11:30, is that correct?
Steve Fields, are you there?
Shall we move to the next slide?
Okay, let's move to the next slide. Let's move through. Let's move through really quickly so you all have time for this too. Okay, so this, I think we started talking about these. These were the, I wanted to highlight some of the themes that came up in our interviews with the 12 CBO providers. So some of the key challenges that came up for driving staffing challenges were lower wages, less competitive benefits packages for both licensed and non-licensed staff, difficulty hiring bilingual staff. Similarly, the BPS number requirement. I want to ask a follow-up question there to you all. The required substance use counselor certification, and just generally, I think contracting with the city came up as a general theme of being challenging in and of itself. And I think, in the last IWG discussion group, I think it was important to note that oftentimes when we talk about difficulty hiring bilingual staff, I think if we talk about it broadly, I think you all have shared that it's important to really think about, down the line as far as specific strategies. That it's important to note that varies depending on the language that you all, that is needed to serve a particular population. But some of the opportunity, I think going back to the conversation earlier that I think you all remarked, which is, like, it's interesting. There's similar vacancy rates, even though we know wages, are different. I think what also came up through the interviews that stood out to us were a lot of the strengths and opportunities that exist among CBO providers, which were just, I think when we asked the question, what are keeping folks here, right? And not just why are folks leaving, but what is keeping people here? And across the board, it was really, folks were like, the really, really strong commitment to the mission and the communities. And that several CBOs were mentioning what has been helping is the ability, both the willingness and the ability to test out creative recruitment strategies, whether it's like internal referrals, internal employee referral programs, using recruiters, developing internal leadership programs. So those are some of the things that came up. Going back to, I think, Member Salinas and Member Ford, we were both talking about the BBS number as well. In your experience, is that a requirement to even apply, or how does that shake out from your experience?
Well, folks can apply, but we just don't have them start till they have that BPS number.
I think that might have been like a point of difference in the currency. I think on the city side, I think folks can't even apply without that.
That would make a difference, because I was going to say that I think that might be sort of standard within hiring. It's not a San Francisco unique problem. It's not a city of SF problem, unique problem. But maybe that part is that we can't even apply. Yeah.
There might be reframing that, like, I think it came up in a few ways in the interview with CBOs, where just the lag itself, for the state processing, that 3-month lag is hard. And then on the city side, it was on city schools, it was can't even apply.
Yeah.
I know it's time, so I want to just open up to what else would you all add when it's not reflected here? Or it's high level.
I think that what's important is we should get to, like, what's this, you know, the strategies, what's the action steps? Maybe we should be online.
Yeah.
Like, how, what are the plans to resolve this?
Yeah. To start to happen. So yeah, let's move through these. I know with time, so let's go to the next slide. Please. We can move through this too. Also, in terms of our process right now, we are summarizing these data, taking the questions that you all have raised today. Not surprisingly, I think a lot of this is going to take a lot of coordinated work across, whether it's pipeline, wages, recruitment, working environment. And I think right now what we're pulling together are based on these themes, like what are the themes that, what are the strategies that some CBOs are already using? We're pulling together what, you know, DHR already has in pipeline, what BHS is already working on. So we're trying to be able to lift up what are some of the strategies that are already underway across city departments. And wanted to open up to you all kind of what is your input to add to the discussion on strategies? And right now is what we can talk about the framing of it. We're not going to talk about, we don't have time to dive into specific strategies today.
Oh, bummer. I mean, when might you be able to come back to talk about strategies? I mean, I think that's what folks really want to hear.
Yeah.
What are the plans to address?
Yeah.
And I think to be clear, you weren't prepared, we weren't presenting them today
Yes.
anyway, so
Yes.
it's not that it was ready
Yes.
and we're deferring it due to time,
Yes.
just, yeah.
Yeah.
I think it's tentatively could come back next month. I think there's a number of, I know you have a number of other conversations underway,
Yeah.
so I think it is one of the potential agenda items for next month. We just.
And
need
then
to
we'll
make
be
sure-
ready. I mean, because there's no need to come back and, I mean, will something actually concrete be ready to?
That's the
report?
plan,
I mean,
yeah,
I-
yeah.
That's the hope,
yeah.
yeah.
So that we can all, you know, talk through and look at the more tangible strategies together. Yeah.
So I think it's one of our proposed agenda items for April, but of course, I know there's a number of other conversations from other stakeholders that are weighing in and just need to make sure that the timeline for all those will work out. So I think the tentative plan is to,
Right now, tentatively.
we're gonna talk about it more this week and then get back to you about whether.
I mean, I'm sorry, I mean, it was all useful information.
Totally.
Yeah.
Do folks have any questions?
I'm just thinking before we jump into strategies, like if we can get the full data, like we do a deep dive on like, you know, how many people are people moving to the city? Why are they leaving?
Sorry. Sorry. Before we get into strategies, like really understanding the data, like doing a deep dive.
Excuse me. Could we pause for a statement from Steve or a question?
His hand up until, I think she started talking. I mean, I guess, because you have to leave.
Go ahead.
That way,
It's
okay.
fine. Go.
Well, we all.
All right, Steve,
Oh, I've been getting ready to have to leave. So the brainstorming strategies is what I want to comment on, but if I can briefly.
yes, please hurry.
I think I would like us to make a statement about the fact that non-licensed behavioral health workers, say comparable to health workers that have been used in the state for things because of their touch to the community, their understanding of the clients they're serving, that's a career path as well. I don't think we want to make a statement that the career path for everyone is to become a licensed professional. Peers and everyone else, and including a whole class of workers who are very beneficial working with clients in behavioral health environments, they should have a career path. It's kind of like saying all teachers should have to have a master's degree in the area they teach. There are teachers that are great, and they should make as much money as anyone else doing that same job. So I would like us to make a statement about the pioneering work that San Francisco has done in substance use and in behavioral health, that it's a career path to be a behavioral health worker who doesn't necessarily want to become a licensed credentialed person in that way. And I'd like us to, because that's what holds back the salaries, the benefits and all the other things as much as anything else. And it's a way of retaining workers in our environments where they make a competitive, good living, being able to live in San Francisco without having to buy into the idea that every good behavioral health care worker has a license. So I'd like us to say something about that very strongly.
Just thinking about strategies, doing strategies before we have the data, like I think we really, like, we see the data, we see that's a problem on both sides, CBO and civil service. Is it really just a salary thing? Because we're seeing the problem here too. Is there something about the work that's happening in the CBOs that makes it like really understanding? And really like the telehealth piece, I think is kind of important because like, just from my experience trying to hire people, there are a lot of people are like, oh, can I work from home? You know, blah, blah, blah. So that's a big deal since the pandemic. And so like sort of understanding that like maybe the thing we need to do is not really raise salaries across the board, but just say, if you're doing like work that involves a lot of hazard or outreach or like is in person 100% of the time, like maybe there is like a pay differential for that, like, you know, instead of just saying, oh, we just need to meet, right, yeah.
Certainly agree with both Andrea and Anna that one, we need to do a good analysis of the data. And then two, from there, we very much need to look at strategies for fixing it. And then, you know, what are we doing this for if not to look at how we utilize it to make things better. Right? So, and I think both things should happen as quickly as we can. You know.
Yeah, I mean, not to mention that there's just a question of what's the validity of, I mean, not, you know, if you don't have an accurate representative sample of those, like, do we need to go back to collect more data and look at some of the details that Ami's mentioned, you know, about the workforce. Yeah.
I think, this has been super helpful. I know we're approaching time. So what I'll do is based on this conversation, I think I was jotting down the data questions that came up. And so we'll come through, put together a follow-up and figure out kind of which of these data questions we have the data to try to address and where we don't acknowledge them and be able to call those out as far as future work that needs to happen based on these questions that are really important for fine-tuning the actual strategies. And then I think we can come back to you all with, based on the data we do have, what are the strategies to move forward? And I think we can hold it as a bow band, like based on what we know, what can we move forward with, and where do we need more information before we can appropriately move towards more specific for fine-tuning strategies. Okay. I think anything else?
Yeah, I have one comment. Yeah. I mean, this is probably not my place to say this, but this was a great presentation. And I think it was a great presentation because you didn't read the slides to us. and it's, I was talking to Andre about this earlier. It's just, we get a lot of people reading slides to us. I think it's really helpful because really gave a lot of time to have discussion on these issues. I very much appreciate it.
Thank you for the space to come talk to you all today. Thank you.
But you got work cut out for you.
We do. We do.
A little bit.
Well, thank you all so much.
Thank you.
Thank you. So Kaylee, can you go to slide 48, please? This is public comment for the staffing and wages presentations. So for those who are joining us online, there are no people from the public joining us in person. If you are joining online and wish to make a public comment, please raise your virtual hand and we will unmute you. You will have 2 minutes to speak. So please raise your hand now if you're joining remotely from the public and would like to make a public comment. Finish this again. I do not see any raised hands. Jen, do you see any raised hands on your end? The chair, I suggest that you are.
So, I guess Steve Boots is still there. Can we approve the minutes real quick? I'm sorry, can we go back to the one section where we would need for sure?
Yes.
Yeah, we can't really perform any business once Member Fields leaves. I hear he's able to stay on till 11:45.
Okay,
We
great.
would do minutes and agenda setting.
So slide 26, please.
So we will now move to discussion item number 2, approval of the February 2024 IWG meeting minutes. These minutes are posted on the IWG website. Are there any changes for the minutes as posted on the IWG website? So I guess we have to have public comment now on them? Okay, no comments on the IWG. Let's move on.
Yes, so if there's any public comment on the minutes from the February meeting, please raise your virtual hand and we will unmute you when it is your turn to speak. When it is your turn, you will have 2 minutes. I will remind you when your time is getting up. There are no members of the public joining us in person. Any members of the public joining us online who would wish to speak, please raise your hands now. I do not see any hands raised. Jen, do you see any hands raised? So I think we can close public comment for meeting minutes approval.
Okay, great. So then we're gonna move back to, discussion item number 4.
You didn't approve the minutes.
That's what we're doing. Well, that's what we're doing now. Now we have to vote.
Sorry, now we have to vote. We're done. Let's move on. Sorry. So,
Now we're on slide 28.
okay, so do I have a motion to approve the minutes? Anybody? Thank you, Member McQuiggan.
Member McGuigan,
And a second?
Second.
All right.
Member Short.
Member Short. I will now, Diana.
So I will now call roll. So if you vote yes, you're voting to approve the minutes, and no, you are voting to not approve the minutes. Member Fields,
Yes.
Member Gonzalez,
Yes.
Member Lipton,
Yes.
Member McQuigan.
Yes.
Member Salinas.
Yes.
Member Short,
Yes.
Member Wong.
Yes.
So 7 yeses and 0 nos. So we have a majority vote to approve the February meeting minutes.
Great. Now we move on to discussion item 4, a discussion to co-fund the agenda for our next few IWG minutes.
So this is slide 49. Thank you.
Meetings, not minutes. Yes, Member Lipton.
Valerie,
Mhm.
do we have any feedback from our meeting last time with either the board or with the mayor about the vacancies?
Yeah, so I consulted with Supervisor Ronan's office to see what they would like me to share. Supervisor Ronan was out for a medical issue for most of the intervening time. And so there has been a delay in continuing from that point. She has returned now, so likely this week we will be picking it back up. So I've been reaching out to her office to schedule a meeting to integrate the feedback. And as I understand it, the next steps would be to draft some legislation that would sort of like summarize potential changes. So that's the next step that I've heard. In terms of filling vacancies, as I've stated before, the deference is to the supervisor's process before they would try to fill additional.
But there's no progress from the mayor's office on what I'll call the alley seat.
The Hallie seat, are we
There's the
making
vacancy
it?
seat too, right?
Remember, there's
2 mayor's
Hallie
offices.
There's at least 2.
There's, so the vacancies.
I was just
include-
thinking the mayor's office.
The vacancies include both board appointed and
Right, no, I know, I was just,
Yeah.
Yeah.
as far as the
But
mayor's
then
office, there's
other-
2 seats, I believe.
Yeah, but with the mayor's a whole other process that
Yes.
doesn't need to be.
Yeah.
They just need to give us the.
deterred
Yeah.
by
Yeah.
the.
Okay.
But it sounds like the mayor will likely defer to, wait at least
Yeah.
until we hear what
The
Ronan's
composition
next
is
step.
So,
So you're really looking for-
so we do.
So the mayor will defer as well to the
I think
BOS.
they would want to make sure that the composition of the seats is determined by the board if they're updating the composition of the seats.
I see.
And thank you, that was on our list. I didn't say that I covered at this point, so. yes.
So you also.
Well, I was wondering whether we should make our own recommendation and submit it to the mayor and Supervisor Ronan
For the,
on the seats,
for people to fill the seats or for the structure,
construction.
for our idea of how to
I
supervise.
don't.
Oh, I think, yeah, if you have additional feedback on the structure of the seats, I think Jackie Krager, who's.
Yeah, I was gonna say, we should do that
Yeah.
through Ronan's office,
Yes.
if they're already, yeah.
Yeah.
Okay.
So this slide shows what kind of based on our discussions for the past couple of meetings, what we were thinking about for the next meeting. My question is, it was not, so I know that we want staffing and wages to come back with a follow-up. I was not clear on the timing, like is next month okay, or is that?
I think it's, so again, they are planning to come back next month, provided they can complete all of the other stakeholder conversations they need to have. So I am meeting with them tomorrow to try to make sure their timeline will fit with that. But I think in service of your time, they want to come back with a full digestion of all the different feedback they're going to get on what sort of strategies to use. So
So already that's too many things regardless.
it is, yeah, these are, and we try to represent options, so.
Well, it might be too soon for the staffing and wages follow-up, right?
I'm sorry?
It might be too soon for the staffing and wages.
It might be.
Follow-up.
It might
I would think.
So I think obviously there's.
I'm pretty interested in those two middle ones, just FYI, weighing in.
The opioid,
Yeah,
overdose?
both the opioid settlement funds and the overdose prevention plan.
Mhm.
But do we
My opinion.
also need to figure out when we're gonna have a presentation on Prop one and what the preliminary thoughts are about implementing Prop one in San Francisco and its impact?
I think
We
that
don't have a precedent, and we still didn't get through the end of SB 43.
So I think SB 43, I might suggest would be a part of Dr. Quinn's update as it was intended to be. I think Prop 1, as Director Brown indicated, is going to take a little more time. So I do think she's more than happy to come back, but I think next month would probably be too soon. It's a pretty major shift, right? And so it takes time to digest those changes and have.
Understandable, but
Yeah.
it would be imperative for San Francisco to be up front and not behind in terms of figuring out how a Prop one would benefit the programs here in San Francisco.
I think there's two simultaneous conversations that are occurring. And say I had to multitask the speaker's issue while Jessica was speaking, so I may have missed what she said about it, but there's what the bond can bring to the city, and that's one conversation, which is multi-departmental about what Procter can do. And then there's changes to how MHSF is programmed. And so those conversations are both sort of early stages. And I think, again, I would want to make sure it's a substantive update. So I think it's not going to be fully baked for a long time. I think there's opportunities for feedback, but I don't think there's that much they can say yet because everybody was waiting for passage. And so I think we could certainly put it on the list. I would just suggest, not for the next meeting, because I don't think it's going to be.
So that would go into the future meeting. So it seems like the opioid and overdose stuff is something that's of interest, and looking at you, Valerie, if that is something that could happen in April.
Yeah,
Especially, sorry, with the opioid settlement funds that the timing is right in terms of going into the budget, city budget season.
Yes, I think so. I think I will note that, staffing and wage analysis potentially may have it's an opportunity to check in before they might publish their findings. And so if they are able to finish their other conversations and come back at the next meeting, I don't want you all to miss the opportunity to give feedback before that memo is finished. So my suggestion would be to prioritize that.
And then so prioritize
If there's
staffing and wages if they're ready
Yeah,
to come back in April, and then have a backup if they're not.
yes. And I think we will know within the next couple of days if there's enough.
So I'm wondering, if we were to have two big agenda items, a noon finish time is probably not realistic.
Yes.
We can, and in addition, if we want Dr. Cummins to present on SB 43.
Yes.
So you would be wanting to allow at least an hour for each one, but that doesn't mean 1 o'clock. That means, 12 o'clock. That means 1
That means
o'clock. So I don't know if that is too much. Or if we need to just boil down to SB 43 and either the staffing and wages if they're ready, or SB 43 and opioid. Do you have a suggestion?
Well, I just think that what the nice thing is we have the slides already for SB 43. So maybe, we can all take a look at them, come up with questions, and instead of her presenting on it, maybe or give her a, high level 2 to 3 minutes, and then we can ask the questions from the slides that we've already seen, I don't know, just to try to save time. Like, I don't think she needs to present everything that's on these slides to us now that we have them. We have time to prepare instead of, getting the day before. So I think that could cut some of the time, if we wanted to try to include more agenda items. Just a suggestion.
Yeah.
I don't know.
I don't think we should include more than 2.
I think we've learned more than 2.
Yeah, but I think we could probably, the SB 43 could probably be pared down.
No.
Including.
Including the SB, we should not, we can't do 3 things. I mean, so I think we definitely want to push back the Inter-Ethica.
Right, and that's probably just a brief update, so I wouldn't count that as one of the major ones.
But then didn't we say SB 43
But we always
would be
say
under
brief
Cummings'
updated.
presentation? I thought we said that.
Yes.
Yeah.
Right,
Yeah.
okay, so we already.
So it's that and one
don't
more, is
already-
I think what I'm hearing. It's Hillary's presentation and then one other topic, is that?
Oh.
Well, no, I think Member McQuiggan was saying it doesn't have to be a full hour.
Yeah, I
So
think
we
since
can-
we have the slides, we could probably have her give a high level, 2 to or 3 to 5 minute kind of synopsis of it and say, hey, you guys have seen the slides. What questions do you have?
Well, I was saying, I thought we already solved the the SB 43 issue, which was that it would be incorporated into Dr. Cunning's.
Right,
Yeah.
yes, and,
presentation. So you're
Yes.
Yeah,
just,
that's what I'm saying.
you're just saying, and she can.
Yeah.
Yeah,
get
yeah,
into more.
yeah.
Got it, yeah,
So
okay.
it's not
So
a,
we
it's
can-
not a full agenda.
Yeah, but I think she'll have other items, so whatever time she has, she has.
So Member Fields?
Oh, okay. I'm jumping in now. Look, I would just like to suggest that the future of behavioral health services in San Francisco is being fundamentally altered by this new trend toward compulsory treatment as a response to some idea, not based anywhere in best practices. So we have SB 43, we have Care Court, and we have Prop F, all have the
Okay,
same
one.
DNA.
Don't forget
And that,
one
I think-
as well, Prop 1 as well. Just
and
saying.
Prop 1 in terms of what it could be like in implementation, which could mirror those. I'm not interested in just getting another report from the department. I want to have an engaged conversation about the implications of what I think are misguided and cynical attempts to ride some wave of involuntary mandated treatment when there's no best practices that shows that it produces better outcomes. And I'd like an engaged discussion with the department and with the behavioral health leadership around that. These are policies coming from outside of San Francisco to the extent that Care Court and SB 43 were imposed, in many ways based on Los Angeles County, which has an inadequate system of care for voluntary treatment. And I just don't want to hear about big philosophical and civil rights changes to a behavioral health system in a couple of discussions like we heard about the SCIRT team and then the crisis stabilization unit. I want to have a discussion of some substance and hear what our leadership is thinking about the complications of implementing a approach to treatment for some of our most complicated clients that's based in the assumption that if we make them go into treatment, then they're going to get better. Thank you.
Yeah. So I want to note the time. I'm wondering, could I continue like agenda discussion with you? Like, can we schedule additional time? Because I think this can take a while.
Yeah.
But we have some moving pieces that we don't know.
Yeah, so I am hearing that a discussion of SB 43 should probably also include care court discussion, and that it actually, warrants a full segment of the, agenda. And so we do need to then think about these other, what else that we would put on and what the time would look like. And then do we really have time for 3? Because I think that we continuously, like, there was way too much put into the first hour today, for sure, right? By any stretch of the imagination. So yes, we'll take let's Valerie and I will plan. We did also, I wanted to say around the HSH, we were supposed to have a sub-working group, but that never, so.
Right, so the update on that is that they needed another month, sorry. did you wanna go?
I can go with it. There was just some unexpected staffing outage on that side that I wasn't able to coordinate with them and give them like a due follow-up in advance. So I think we're at the stage where we can do that now. I've informed them, and so we can reach out for a discussion group and get that set up. So it was just a staffing.
Yeah, so at any rate, then the HSH discussion was getting pushed back a little to like probably June or something, and then so then in interim, we can have our discussion group.
Yeah.
And then we can really just put that up on the agenda
Yeah.
to follow that soon after, so that it doesn't, so some other things are definitely gonna get put back, but we'll prioritize what's figuring out April meeting based on those priorities that are currently in April with something getting moved back to May. Okay? I'm good?
Yes. thank you.
Wonderful. Thank you so very much.
For your leadership. Thank you.
Thank you so much. And I will be in touch with you, Valerie. And then I do want to say that I did send out, no, I mean, not yet. That's not true. That's not.
We have public
let's
comment.
adjourn. Or
We have
public comment, sorry.
We have 2 public comments that we need to do. One is for IWG meeting planning, and then the other is for that generic anything else one.
Yeah.
So there are no members of the public joining us in person. If you're a member of the public joining us online and would like to comment on meeting planning, please raise your virtual hand now and we will unmute you, and you will have 2 minutes to give your public comment. Fresh. I don't see any virtual hands raised. Jen also does not. So I think we could close public comment for meeting planning. And then going to the next slide, which is public comment for any matters within the jurisdiction of the committee that are not on the agenda. So once again, if you are a member of the public joining us online and would like to comment on anything else, please raise your virtual hand now. I do not see any virtual hands. Jen, do you see any virtual hands? So I think we could close this public comment as well.
Great, Aries are back to HSH group.
Yes.
So.
We already touched on it, so we could go to the next one.
So.
And this is just the information about other bodies.
All right. Thank you, everyone, for this meeting. Our next IWG meeting is on Tuesday, April 23rd, starting at 9 a.m. at our usual location. Can I have a motion to adjourn?
I motion to adjourn.
Short
Second.
and McGuigan.
Meeting is adjourned. Thank you.
Thank you, Chair.
Thank you.
Thank you. Once we get more members, we can have quorum and quorum. Quorum. And then also, if like anyone's running late, we could still start.
Exactly.
Yeah.
I wanted to
And we'll
ask,
have to end early if someone is late. Yeah.
Yeah.
would it be, so one item we considered